mechanical support and transplant towards the long term.
Thank you, Andrew. Thank you, everybody, for staying behind so late on a Friday afternoon. So the aims of the afternoon talk, hopefully by the end of it you'll have an understanding of the indications and contraindications for heart transplantation and mechanical circulatory support, who to refer and when, give you an idea about survival post-transplantation and NCS, and some of the complications related to transplantation. And NCS is not all fantastic. So it is the 50th anniversary of heart transplantation this year. And if I could try and get you back to imagine at that time, in 1967, when Christian Bernhard did the first human-to-human heart transplant, and Louis Shanks, who's here, was the first man to have a heart transplant, and this was the donor, and a young 25-year-old name, a lady by the name of Denise Starwell. Louis Shanks survived for approximately 18 days, and he had what they thought at the time was rejection, and gave him more and more immune suppressants, and at the end, when they did the autopsy, he realised that he had a pneumonia. At that time, Ernest Shumway had already done a dog heart transplant and was regarded as the father of cardiac transplantation. And Yuri Gagarin had sort of gone around the orbit of the Earth as the first man in space. And there was literally a feeling of man could achieve anything, and there was no barrier, and there was going to be a cure for heart failure. But once they did the first heart transplant in Cape Town, they soon realised that it wasn't the sort of the nirvana, the holy grail that everybody was seeking. And survival post-transplantation in that early period was pretty poor. And actually, the number of transplants that occurred dropped down to around 100 from 100 in 1968 to just 18 in 1970. And there were only a few believing centres that carried on transplanting. They were in Stanford and Cape Town, where Christian Bernhard was, and in Paris, France. And it was basically three key discoveries that led to transplantation being the treatment that it is today, and the treatment that offers such great benefit to some patients. And these are the discovery of cyclosporin. And you can see in some of these curves, when Christian Bernhard did his heart transplant, they were giving steroids and azathioprine, and survival wasn't that good. 4 years, it was pretty poor. But with cyclosporin, it improved significantly later on. The other thing was the development of the technique to diagnose rejection and take snippets of cardiac muscle without opening the chest and having a look under the microscope and diagnosing rejection by looking at immune cells, T cells within the myocardium. And you can see that in this histology section with this piece of myocardium with lots of T cells within it, indicative of rejection. And the third thing that led to transplantation becoming established was the idea that you could take a donor heart and preserve it in ice for up to 4-hour period, and which allowed potential donors to be far away from the recipient, and to allow the donor to be transported to the recipient to allow the heart transplant to occur. Before, when Christian Bernhard did his heart transplant, did the heart transplant of Louis Shanks, the recipient was in the neighbouring theatre. So these three advances really allowed transplantation to take off. And currently, in most of the transplant centres in the UK, we use a system called the organ care system, where you can take the heart out of the donor and you can keep it beating. And so the ischemic time is a lot less, and the heart is beating and allows the surgeons more time to use the donor heart. There are currently 6 adult heart transplant centres in the UK, with Glasgow up in Scotland, the Freeman, Newcastle, Birmingham with Cern Limworks, Harefield. We've obviously got Great Ormond Street Hospital, Papworth and Henfield. And this is Sir Mehdi Yaqub, who got knighted by the Queen as being one of the pioneers of transplantation in the UK. And in the 1980s, once these three sort of innovations came about, the number of transplant centres across the world just increased rapidly, and the number of heart transplants that occurred also increased to roughly around 4,500 a year, and that's actually gone up in the more recent times. And this is in the background around that time, in the 1980s, of very little heart failure medical therapies at hand. And again, it's a testimony to modern science and modern pioneers in heart failure management. And without embarrassing Professor Cleveland, he's been involved in some of these trials, that actually medical managers substantially improved outcome for our patients. And this slide is a really nice slide made by Professor McMurray, just highlighting all the trials over these last 30 years that have occurred, from the ACE inhibitor trials, the original hydralazine and nitrate trials at the beginning, and then later on we had the beta blocker trials and some of the device trials. Professor Cleveland was involved in the CARE-HF study, and more recently the Paradigm trial. And so it's every decade there's at least several medicines that are becoming available, improving survival in transplantation. But if you go back to 1988 and open a textbook of Brunwald, which is widely regarded as the father of modern cardiovascular medicine, and you open that textbook up and looked at the survival of transplantation with heart failure at 5 years, it was 20% at that time. And with all these medical therapies now, the survival at 5 years is around 50%. So massive amounts of progress made in the last 30 years. However, having a diagnosis of heart failure is still, and you've heard from the morning talks and the afternoon talks, is a pretty bad diagnosis to get. It is akin to having some cancers. Breast cancer, for one, has a better one-year prognosis than being told you have heart failure. And hence the reason we had a palliative care talk earlier, and the importance of having palliative care within your heart failure programs. And again, we've had these slides before. Being admitted with acute heart failure, is a poor prognostic sign. You're at risk of dying quite early. Within a year of hospitalisation, 30% of people that have heart failure are not alive, and in hospital, first-day mortality is also is quite high as well, around 10%. And what can transplantation offer you, or can offer your patients, is from the time of transplantation, the median survival is 11 years. And if you survive the first year from transplantation, your median survival is 14 years. And that means 50% of patients following a heart transplant, if they survive the first year, will live beyond 14 years. And you're not only talking about 14 years with breathlessness and NYHA class 3 or 4, we're generally talking about patients who have NYHA class 1 symptoms and can go back to work and live active, healthy lives. And this just highlights the point that the number of readmissions or hospitalizations is not that high, actually, and very few people get hospitalizations. Often they have other problems, so transplantation isn't the wonder cure that I'm trying to project at the moment. There are issues with it, and partly related to the chronic immune suppression that you have to take. Most commonly nowadays, it's tacrolimus, which is very similar to cyclosporine, and mycophenolate. These are common immune suppressants that are used. But the consequence of using these immune suppressants is you develop a combination of problems over time, and that leads to the patient's demise. And that's why survival isn't as as it would for the age-compared person. So hypertension within 5 years is around 90-odd%. Renal dysfunction, okay, you might say if you have mild renal dysfunction, we can accept that, but a lot of the patients develop severe kidney failure, requiring dialysis or transplant, and within 5 years it's around 18% of the patients, and at 10 years it's around a third of the patients. Graft vasculopathy is another name for developing transplant-related coronary artery disease. Also becomes quite common. Nearly 50% of the patients at 10 years will have significant coronary disease requiring a stent or some kind of intervention. And diabetes, because you have to take, a lot of centres use tacrolimus and it's associated with diabetes, and use steroids, isn't uncommon either. And obviously with all these risk factors together, that leads to other complications with eye problems and peripheral vascular disease and so on. And this is a really busy slide, but I just wanted you all to take a couple of points away from it. Early on in transplantation, graft failure essentially means the heart stops beating for whatever reason, just doesn't work. It's quite a common reason for not surviving. But if you get beyond that period, your survival is very good. And most people after that will succumb to a couple of issues. Again, renal failure, malignancy, one of the things because you're immune suppressed. And rejection actually happens very, very seldom. I'm trying to pick it out on here. Only around sort of 0.% of the cases towards the end. So who should be referred for transplantation? And when I think you saw the slide that Andrew had this morning, the timing of transplantation is crucial. If you send the patient too soon, then you're putting them through unnecessary risk of the operation, and you're exposing them to long-term immune suppression and the consequences of that. And if you refer them too late, and by that I mean they have already developed significant renal failure from cardiorenal syndrome, developed liver failure from right-sided heart failure, or respiratory failure, then the risk of the operation itself increases and survival post-transplantation is less likely. And getting the balance right is really, really important. And I would sort of debate on whether I should put this slide up or not, but I think in the end I decided to. Forgive me if I do offend anybody. But I was looking at breast cancer and thinking about breast cancer, and if a 50-year-old lady with suspected advanced heart failure and you had a 50-year-old lady with suspected breast cancer, the NICE guidelines say anybody with suspected breast cancer should see a specialist within 2 weeks or 30 days of having that suspicion. And what I'd like to see is anybody with suspected advanced heart failure should be referred very quickly. But there are no such guidances. But that is how I personally would recommend treating these patients. Because if you refer somebody with breast cancer who's developed MET and you refer them 3-4 months later, you know, that patient has every right to sue you or sue us as healthcare professionals for referring them too late. And in a similar way, if you refer patients with advanced heart failure who've already developed renal failure or liver failure, then there's very little we can do as a transplant centre in trying to rescue the situation other than using high-end technologies like VA ECMO and Impella and things like that. And it almost becomes more of a salvage procedure rather than a real treatment that may have benefit. This is, I think, an important slide. It lists the UK criteria for listing for adult heart transplantation. And you can look on here, there are actually most of the things you could get from your local hospital. And it's actually quite easy to get on the UK adult heart transplant list. And if I can go through them with you, if you don't mind, persistent NYHA class 3-4 symptoms despite optimal medical therapy. And we've been through what is optimal medical therapy earlier, ACE inhibitor, beta blocker, aldosterone antagonist and devices. If you carry on having persistent symptoms despite that, you know, think about referring. You only need one other criteria to be listed for transplantation. A BMP greater than 400 or N-terminal pro-BMP greater than 1600 despite treatment is an indication. 2 or more admissions with decompensated heart failure. We've already seen a few slides from earlier speakers where if you are admitted with acute heart failure, you're at high risk of death. If you're admitted with a de novo diagnosis, then you have potential options. You can start patients on ACE inhibitors, beta blockers. You can help improve the patient's outcome with reverse remodeling, and maybe the LV function will recover. You saw Professor Cleland's slide earlier, where 15% of patients actually do recover their myocardium, and another 50% of patients will have stable left ventricular ejection fractions. But if you're already on these drugs, if you've already got your device, and you've been admitted with acute heart failure admission, I would put it to you that that patient potentially has advanced heart failure and needs to be discussed with the transplant centre. One of the things that often catches people out is pulmonary hypertension, and I see referrals often with patients who've had dilated cardiomyopathy since 2008 and will be on optimal medical therapy, are regularly seen on a 6-monthly basis in clinic. And you can see on hindsight that the PA pressure on the echocardiogram has gone from 30 to 40 to 45 to 60 patients in NYHA class 2. And then 5 years later, in 2017, they now are NYHA class 3, and they have an acute heart failure admission, and then they get referred. But by that time, they've already developed pulmonary hypertension, and that's one of the contraindications for transplantation, and the whole thing's too late. So monitoring the pulmonary pressure with echo in a patient who's on optimal medical therapy and keeping your eye out for that is actually one of the important things that what we ought to be doing. Again, these are self-explanatory. Deteriorating renal function due to cardiorenal syndrome, and that's quite obvious. You're on optimal medical therapy, your creatinine starts going up. Why is it going up? You know, what's happening is that the patient in a low cardiac output state now, and things getting worse because of that, or is it something else? Have they got diarrhea and they're dehydrated? Yes, but think about it and have that suspicion and make that referral. One of the other things that often happens is ventricular arrhythmias. So I recently did an audit of all the referrals, heart failure referrals that we had at our centre, and approximately 70% of the patients that were referred had problems with arrhythmias as one of the signs of them decompensating and worsening. So really bear that in mind. And if you're going to refer to an electrophysiologist for an ablation, as far as my understanding is, and I hope to be corrected by everybody here if you know, but VT ablation in somebody with LV dysfunction doesn't improve your mortality. It might improve your morbidity and hospital readmission rates, but it doesn't improve your survival. And putting a patient with severe LV dysfunction who may well be in a low cardiac output state through an ablation may actually make them a lot worse because it's quite a big procedure to go through. So just have that suspicion. The VT ablation may not be the right answer. Just think that maybe this patient has a low cardiac output state and needs to be assessed for transplantation. Again, deteriorating liver function and symptomatic pulmonary edema and congestion despite optimal medical therapy. I think it's all fairly self-explanatory. And we've seen the Seattle Heart Failure score as one of the earlier on in the day. I'd recommend that you use this in your clinics if you can, if you have the time. It's very easily accessible. You just go on their website and you can put all these details in and get an idea of what their likely mortality or survival is in over the next 1 to 5 year period. And if your patient, when you put in their age, their MRHA class, their ejection fraction, the current treatment, their devices and so on, if they have a 1 or 2 year survival that's around 90% or 80%, then they may be eligible for cardiac transplantation. As I mentioned earlier, about 10% of patients will not survive the first year of transplant. So if they have a 50% or 80% survival at 1 year, they have less risk by having a heart transplant or an LVAD. So some of the contraindications for transplantation. I mentioned earlier pulmonary artery pressures of above 60 are a contraindication, and I'll try and explain why that is. If you take a donor heart out of a recipient, donor heart out of a donor who's brain dead, this person's supposed to have a normal heart and normal physiology. This heart is supposed to have been beating in a donor who doesn't have high pulmonary pressures. So this heart is not used to pumping against high pulmonary pressures. If you take that heart out, put it on ice and it's not beating, then put it into a recipient who has pulmonary hypertension, the heart, not only does it have to wake up and take time for over a 24, 36 hour period to wake up, but it also then has to work harder than it's ever had to work before. And it's very obvious that the risk of the graft failing is going to be higher. And as a result of that, anybody with PA pressures above 60 or pulmonary vascular resistance above 5, and these are things that you can only work out with a right heart catheter, if they are that high, then they're not eligible for transplantation and they need to have other treatment. A BMI above 35 is also a contraindication because the outcome's a lot poorer, and you have to basically get the donor to be matched to the patient's size. So finding a donor, and it should be within sort of 30% of the recipient's weight. So finding a donor to fit somebody with a BMI above 35 is difficult and is also associated with primary graft failure. Age is not supposed to be an absolute contraindication, it's a relative contraindication because we don't want to discriminate. We've actually got somebody on the transplant list right now, on the super urgent list, who's 72 years of age. He physically looks like he's 60, but it is possible. We've transplanted somebody before at the age of 70. It's not very common, but we're not against it. But yes, the outcomes actually, if you look at the ISHLT registry over the 10-year period for patients who are above 65 who get transplanted are exactly the same as patients below the age of 65. So it's not a contraindication. Clearly, if they start to get above 70 and the older they get, the outcomes may get worse. Diabetes is a big problem. If you have a HbA1c over 7.5%, or you have microvascular complications like proliferative retinopathy, neuropathy, or nephropathy, then that is a contraindication. So I'd encourage you, before you refer your patients, if you could get that assessed, then that might save a lot of hassle and get diabetes control spot on. These are all self-explanatory, so active infection, you don't want to immune suppress somebody who's got an active infection. A very low EGFR, less than 30, is a contraindication because you end up going on to calcineurin inhibitors like tacrolimus and cyclosporin, and you end up completely wrecking the kidneys, and the patient have a transplant and will then need dialysis for the rest of their lives. Pulmonary malignancy, for obvious reasons. So one of the things you have to consider with transplantation is you have to consider the donor. You have to consider the person who's on the transplant list waiting for a heart who doesn't get a heart. And so you have to consider all these factors and maximize the benefit of a scarce resource. So you really have to think that, what the recipient I'm giving this to, are they going to be able to use this gift and maximize its potential? So compliance becomes an issue, and if you have somebody who's not compliant to standard heart failure medicines, it doesn't feel appropriate to be then giving them a heart transplant with the risk of them not taking their immune suppressants afterwards. Frailty is also a big issue. You can do a heart transplant. The surgeon's very happy to do a heart transplant. They're very happy to operate, but then you have a patient who's bedbound with a perfectly functioning heart but can't actually mobilize anywhere. And obviously CVA is not an absolute contraindication. We've had somebody with muscular dystrophy recently who's wheelchair bound, who leads an active life, is a psychologist with a PhD and works in the NHS, and she's back at work without a problem, has been wheelchair bound pretty much most of her life. So having disability in itself is not a contraindication, but it needs to be thought through carefully. So one of the big problems is if we could transplant everybody with heart failure, I think we'd have massively improved survivors, but the big issue is donor shortage. And actually in the UK, we're not very good if we compare ourselves to other nations that like in Europe and in the USA, where we donate maybe 17 per million. And we could do better, and there are initiatives constantly going on, but that is the big problem with transplantation. There is a shortage of donors. In the UK, we do approximately 180 adult heart transplants a year, and there are approximately around 250 patients waiting on the transplant list. So, as a result of that, in the 1980s, the solution to this donor shortage was the Heartmate IP LVAD. And this is where LVADs come in and have really saved the lives of many people who have been waiting for a heart but are not unable to get it. And the role for an LVAD is and the niche is there. This is the first Heartmate LVAD that came out, and this is the big washing machine kind of structure that you were sort of tethered to. Things have sort of moved on since then, but if I can take you through it, the actual pump, which is here, was about 5 kilograms in weight, and is divided into two chambers, a blood chamber and a gas chamber. And this driver would pneumatically drive air into here and basically move a polyurethane diaphragm up and down, and that action would force blood to move in one direction, essentially with these porcine valves in the inflow cannula and the outflow cannula. The inflow cannula is attached to the left ventricle, and the whole action of the pneumatically driven air would allow about 6 or more litres of cardiac output in a patient who probably had a cardiac output of around 3 or so. Now, the device was very heavy. This is what it looks like with a photograph. And because it was big and it had multiple moving parts, it was prone to malfunction. And it was also could be used in quite big patients, and that essentially meant men. And if you're a small woman or if you're a child, then this wasn't a therapy that was available. And so the second generation LVADs that came out turned out to be a lot better. And if I can talk you through it, it's a lot smaller in size, and it only had a single moving part. It was an Impella device with a helix on it, and it would rotate at several thousand revolutions per minute and would suck blood out of the left ventricle and pump it out into the aorta. And because there was no pulsatility, and the original VADs were often called pulsatile VADs, there was no urethane diaphragm pumping air in a pulsatile way. There's continuous flow through systole and diastole, so you often don't feel a pulse in these patients. And these second generation LVADs are proved to be more durable. And the more commonly used VADs nowadays are the third generation LVADs, and you can see they're getting smaller and smaller in size, and you can fit this in the palm of your hand. This one has an Impella device on the inside, which is magnetically levitated, and that means there's frictionless movement, and it's less prone to having complications and so on. And it's also easier for the surgeon to implant the device. And in fact, our surgeons implant them with a 10 centimetre thoracotomy device, sparing the sternum and allowing the sternum to be used when the patient's bridged to transplantation at a future date. So these devices were tested in randomized trials, and there are very few of them in advanced heart failure therapy. There are a couple. And the original one is the REMAT study in 2001. Patients in optimal medical therapy were randomized, patients were randomized to optimal medical therapy and the Heartmate 1 XVE LVAD. And at 2 years, the survival in the medical therapy arm was around 8%. And in those patients with the VAD was around 24%. And these are patients, I think 70-80% of them were inotrope dependent, and 20%, the other 20% were NYHA class 4 patients with cardiac outputs and cardiac indexes in the cardiogenic shock kind of range. Most of this was a destination therapy trial, and by that I mean the patients weren't suitable for transplant, and the main reason they weren't suitable for transplant was because their age was too high. So it gives you a flavour of the kind of patients they use in this trial. And you can see there was a significant improvement in survival at 2 years. This VAD was then randomised and tested against the second generation LVAD that I showed you earlier in the Heartmate 2 destination therapy trial, and suddenly you see an even greater improvement in survival. And what they did show was in the standard care arm, in the Heartmate 1 LVAD, it repeated the survival that was shown in the REMAT study, i.e. survival was around 24%. But those patients who had the Heartmate 2 LVAD had survivals close to 60%. So at 2 years, suddenly you have patients with optimal medical therapy only having a chance to survive 8% to now 50% at 2 years. The most recent LVAD, the Heartware LVAD now, has been studied in a non-inferiority study, and registry data now suggesting survivals at the range of around 70% at 2 years. That's massive improvements in comparison to medical therapy. So this is real-life data from the INTERMAX registry, which was established in 2006 and has approximately 16,000 patients who've all had left ventricle assist devices. They started off with mainly having the continuous flow pumps, the Heartmate 2 LVAD, but more recently now, more and more centres are putting the Heartware LVAD in the centrifugal magnetically levitated device. And from this registry, contemporary survival at 4 years is around 48%. And the first 2 years is comparable to transplantation. The kind of patients that are getting these devices are sort of INTERMAX 1, 2, and 3, and 4 patients. And I think maybe Cern and Andrew mentioned this classification before. It divides patients in NYHA class 4 into a sort of more groups, because you can get patients who are in critical cardiogenic shock and literally have hours or to survive, and that they're different to the patients that have a few weeks to survive, and they're different to the patients who are stable on inotropes and are doing quite fine and look fairly well on your wards. And then those patients who are not on inotropes and are NYHA class 4. But LVADs are not without their problems. And if you look at their event-free survival, and by that I mean freedom from bleeding, device malfunction, stroke or death, and infection, then at around 3 years, only around 20% of patients are free of any of these complications. So it isn't the complete answer, and it's clearly not as good as transplantation. But for patients who are desperately waiting and their life depends on waiting for a heart transplant, these devices can bridge you to a heart transplant at a future date, with the hope that before any of these complications occur, you get a heart transplant. So who gets an LVAD instead of a heart transplant? As I said already, LVAD as a bridge to transplant in patients who are pulmonary hypertensive. So if you remember the patient earlier who I mentioned to you, the pulmonary pressures are going up and up and up, they're no longer eligible for transplant. What actually happens now is these patients become bridged with an LVAD. Because once you put the left ventricle assist device in, the idea is that 80% of these patients over a 6-month period will have lower pulmonary pressures, and which allows them to become transplanted afterwards. What effectively happens is they end up having 2 big operations. One, the LVAD, and second, the transplant. So if you can avoid getting into a pulmonary hypertensive state, just refer them earlier. And obviously those patients who don't have time to wait, who are crashing and burning, can't wait for their transplant. So obviously you have to match the blood group and size and so on. If you have a 90 kilogram man whose blood group O, their projected waiting time currently in the UK would be close to a year. And if you've got somebody who's very ill and can't wait a year, then this becomes, LVADs become life-saving therapy. Within the UK, LVADs are currently not being used, or we're not allowed to use them as destination therapy, as in you put the device in, that you're expecting the patient to live out their life with the device. We're only allowed to use the device as a bridge to transplantation. But outside the UK, in the US and in Germany and a few of the other European centres, they are implanting these devices as destination therapy, and those patients are often above the age of 70 and even in their 80s, and have higher BMIs and are highly sensitised, which essentially means they have lots and lots of antibodies against potential donors, are very, very unlikely to get transplanted, because if they were, these antibodies would attack the heart and it wouldn't survive. So contraindications to left ventricle assist device surgery are actually very similar to transplantation. If I can simplify it, essentially, if you develop liver failure, severe renal failure, or severe lung disease, and you end up on a ventilator, if you go through an LVAD operation, your chances of surviving it become dramatically lower. So it seems odd to say, the fitter you are going into an LVAD operation, the more likely you come out of it. But these are the kind of patients, if you have the crashing and burning patient in your DGH in your hospital and they have renal failure, liver failure, what will probably happen is they'll have a VA ECMO device or some other kind of mechanical circulatory support to try and recover the liver failure and the renal failure, to allow them then to either have an LVAD or to have a transplant at a later date. The other contraindications are infection, malignancy, PEs, pretty much similar to what we found, what I told you earlier about transplantation. We've got a couple of case histories, I'm doing for time, okay, to just have a bit of interaction, and maybe we can talk about it in an informal way. These are real patients that I've literally had in the last month or two. A gentleman, 54 years of age, dilated cardiomyopathy since 2012, optimal medical therapy, CRT device in September 2012, had renal impairment, cracking around 160, EGFR 445. And in 2015, so a couple of years after the CRT device goes in, he starts having VT episodes, successfully treated with ATP. And prior to that, he'd had no ventricular arrhythmias. You can see where this is heading. Yeah, he was referred for an ablation, so December, VT episodes, March, 4 months later, VT ablation. That helped a bit, but actually he got readmitted again in May, so now we're looking at 6 months later. He gets another ICD shock, recurrent VT, decompensated heart failure, creatinine of 290, BNP of 13,000. He was referred to our centre, and unfortunately he passed away. We tried to salvage the situation with ECMO, but he just went into multi-organ failure and died. I was incredibly saddened by the whole thing, because actually around here, he was a 54-year-old man who was otherwise fine, didn't have any of the end organ problems, bit of renal failure, he could have been transplanted. And he would have got heart failure quickly. Second patient, 58-year-old male, better outcome, so didn't want to depress you all. 2008, dilated cardiomyopathy, on optimal medical therapy, ICD implanted for primary prevention, wasn't suitable for CRT, which Andy was telling you about earlier. He'd been between 2009 2016 in NYHA class 2, baseline creatinine of 120. January 2017, right, suddenly starts getting more breathless, NYHA class 3 now, persistent AF, treated with amiodarone, cardioverted back to sinus rhythm. 3 months later, March, VT, ICD shocks, angiogram, normal coronary arteries. April, now where we're getting to, 4 months later, readmitted, heart failure, broad complex tachy, DC cardioversion, sinus rhythm, amiodarone, now with a creatinine of 200. And this is when he was referred to Harefield. This is right heart catheter data. I apologise for this. I'll try and make it palatable. Essentially, this is his right heart cath data. He had a cardiac index of 1.7. If you go back to that list of data I was telling you, cardiac index is less than 2. You're in a low cardiac output state, not a good sign. He had a high wedge pressure of 28. It should be less than 15. So high filling pressures. He's in a lot of trouble. And this is on an inotrope. He'd been on an inotrope for a week. We hoped that would improve his renal function. But even on an inotrope, his renal function wasn't improving, and he had a low cardiac index. Creatinine was 200. So what we did, we put an Impella device in, and CERN showed you a really nice schematic of that before, but essentially it's a percutaneous device, and it gives you 3.5 litres of cardiac output. It's done through the groin, and what it does, it has a rotating motor here, it's very small, and it sucks blood out of the left ventricle and pumps it out into the aorta and gives you an extra 3.5 litres of cardiac output. And he was in a low cardiac output state. If we can improve his cardiac output a bit more, maybe get it up to 6 litres a minute, maybe his renal function will improve then, and he will become transplantable. And luckily for him, he did have his kidney function did improve. He had the Impella device in for at least 2-3 week period, and he was put on the super urgent list, and within, I think, 6 to 8 days, he got a transplant, and he's going home next week. And this was a real success story. But his creatinine was 220 mg/min, and there was a moment we thought the Impella device wasn't going to help, and perhaps he could have been referred a bit early. Finally, so my last case, a 60-year-old lady, HLA negative, blood group A, and when you say that to me, my ears perk up because I think, wow, she's going to get a heart transplant really quickly. Cardiac sarcoidosis in 2009. On maximal therapy, LV dysfunction, EF 25%, and an ICD as part of primary prevention, previous ablation, VT ablations. Being followed up in the heart failure clinic on a 6-monthly basis in this time period. And you can see, and this is, I haven't made this up, this is a real case. This is her PA pressure, 35, 38, 43, 47, 54, 65. Remained NYHA class 2 on optimal medical therapy, and the routine clinic conversation was, oh, you're fine, I'm fine, we'll see you in 6 months, creatinine's fine. And then she goes into NYHA class 3 and gets referred to us. We do a cardiopulmonary exercise test and just feel knowledge. If you have a peak oxygen uptake less than 14, you're in the transplant range. And she had a peak oxygen uptake of 8.8, which is 30% predicted for somebody of her age. And anybody below 50% is deemed suitable for transplant. This is her right heart cath data, and again, apologies for all these numbers. I'll just try and walk you through it. The PA systolic pressure, the pulmonary pressure, this is now gold standard measurement of pulmonary artery pressure, it's 55 without any drugs. This is without, apart from her standard heart failure meds. She had a pulmonary vascular resistance of 5.08, so transplant range is below 3. So with these numbers, she's not transplantable. What we can do is give milrinone because her wedge pressure is up, her LV isn't pumping enough blood out, and as a result, the wedge pressure, the left atrial pressure is very, very high. So the idea is if we give inotropes, we lower the wedge pressure, and it will improve the cardiac output, and perhaps be able to lower the pulmonary artery pressure. But we give milrinone, and that doesn't happen. So then we gave SMP at the same time, and her PA pressure did drop, but her pulmonary vascular resistance remained above 3. And so she ended up going for a left ventricular assist device. and she got through it, had an uncomplicated procedure, and went home, and she's fine, she's doing really, really well. But actually, if you go back to that breast cancer patient at the beginning, you see somebody who's already metastasized, already got high pulmonary pressures, and you actually see and watch the pulmonary pressures going up, you've done a disservice to your patient. And actually, she has grounds, to, in my view, to take issue, because she's now having to go through the potential risk of having an intracerebral bleed, a stroke with the LVAD, and becoming untransplantable. And she has to go through the whole transplant as well. Thank you for listening.
Wow, well, so fantastic talk, diving through those long-term LVAD transplant.
Thank you very much for a very nice update. With the evolution and the development in technology, do you think there will be time where we'll have a completely artificial hearts that are transplantable for patients? And I know they are probably working on them now, but do you think we are there or close to be there?
There is a total artificial heart that is being used, but my personal view, and you can ask Dr. Bowles, who is also very expert on this, I don't think they're at a position right now where they can really be an alternative to transplantation or ventricular assist device surgery. So you're right, you're alluding to the fact that the left ventricle's failing and that we've got an LVAD, but what happens if the RV is completely shot to pieces? You know, the LVAD will actually make the situation worse than those kind of patients. And yes, we've implanted around 17 total artificial hearts, is that right, Chris? I can't remember. But you know, the outcomes with it are not that great, and you know, it's still an area that needs developing, and maybe in those 10 years, because all these changes with these left ventricular assist devices, these miniaturizations sort of happened in the last 15, 20 years, and who knows what the next 10 years will bring. It's brilliant.
Yeah, there's a couple of your selection criteria that I think should be reviewing. There's a hemoglobin A1C of 7.5 is associated with optimal survival in a diabetic with heart failure. So why is it excluded from transplant?
So, you know, I haven't been involved in setting up the guidelines, but what I can say in our own practice, we're a bit more flexible. So, you know, we have transplanted people with HbA1c. These are sort of relative contraindications. I think we have too many.
Just to beat it. I think you're fair enough with the nephropathy and retinopathy, but I think just the hemoglobin A1c, that's the reason to deny the patient life-saving treatment. With the renal function, we see a group of patients with really bad heart failure and awful renal function. We get better and the renal function returns to normal. So what are you doing to make sure that that renal dysfunction is fixed? And we should be talking about CKD in heart failure. We're trying to get rid of this topic. We had a big conference in Athens, as a place to go, 2 weeks ago, and pretty well there was a big argument there, but I think that we're going to get rid of CKD from heart failure because it's GFR we should be talking about, because it depends on your cardiac function, where your renal function is going to go. So do you put in a temporary assist device and sort of look what happens to the renal function of these patients?
Yeah, I mean, I'd say that the example of the Impella patient, I think it's a classic example of somebody who has low cardiac output related renal failure, and if you can prove that it's all low cardiac output related, then yes, they can become transplantable. What we're trying to do is differentiate those patients who have intrinsic kidney disease that's irreversible, which will, when you put them on immune suppression, will then invariably mean that they'll need dialysis. And it's just trying to tease out these patients. And you can put VA ECMO and Impella devices to help improve the cardiac output, or even simple things like a balloon pump or an inotrope. And you've all seen patients who come in with renal failure, put on a bit of inotrope, the renal failure improves. And I mean, I do that day in, day out, and that's what I see. And
10 pound weight loss?
Yeah.
Lots of patients lose 10 pounds with their heart failure.
Yeah, I think the general principle is that you want to make sure that they're going to get maximum benefit from a limited, scarce resource. And yeah, we are very flexible.
So it perhaps goes wider, not necessarily directed at yourself. exercise is, so again, coming back, so we've heard pharmacological, we've heard mechanical. What about exercise as potential? I don't know if there's any evidence. I'm not from a clinical background, so it goes to a wider...
You're absolutely right. You know, cardiac rehab exercise is as good as taking medicines, and Professor Clean's probably...
I was going to say on that point,
to answer that question, then I'm not an expert in it, but...
Is there any advice on that?
Yeah, there is a large randomised controlled trial was done, several have been done. What they persistently show is that as long as there's somebody there coaching the patient, they will do the exercise. As soon as you stop coaching them, you return to watching television. So they may say they like it, but they don't persist for whatever reason. It doesn't make a difference to survival, but psychologically, the patients seem to have a better psychological profile if they are pushed to exercise and take some exercise. I think it's about controlling, being in control. But of course, if you run a Zimmer frame,
yes, of course, yeah.
Nobody's done a proper randomised controlled trial of hand exercise for those people whose hips don't work anymore.
If you're interested, there's a Professor Rob Taylor who's ex-university who's done a lot of work on exercise. Right, yes, cool. It's got to happen. You talk about scarce resource. I mean, I noticed the UK is pretty low on the list of donors. What is the sort of waiting list, or is there anything that you can see you've done to improve the
I would just get yourself on the donor register and make sure your families know that that's what you want, because often it's not the patient. The patient's probably on the donor register, but if the families say no, then even if you're on the donor register, we can't do anything. But I think they're
Why is that then? If we've had one like that. So if your wishes are paramount, for everything you do, we have to listen to the patient.
Yes.
So if the patient has taken the trouble to sign up for the register, has got their donor card, and desperately wants to donate, but the family say, oh no, can't have Uncle Fred cut about, but because that's, how can they go against his, how can it be right that they...
I agree with you, and I'm not against what you're saying, but I think it's to do with the who's responsible for the patient, and they, the next of kin, effectively become the patient's advocate, and that's where it is. And I personally think it's wrong. I think we're if you see a patient on our ward that's has 2 kids and a wife, and you would never deny that patient the chance of living a normal life. I completely agree. I don't know how we can change it other than you guys going out and registering and telling your families and spreading the word to everybody.
And we're moving towards not out.
We are in Wales, and I think they're piloting. Chris, I'm not sure if you can... In Scotland, yeah. And so I think there are plans to get that out nationally as well.
Going back to it, is there an actual average weight that you would say if someone's on the list waiting for a transplant, how long do they have to wait for?
So it can vary. There are different types of priority lists. So on a routine waiting list, to be honest, you're not going to get a transplant, unless you may be blood group AB, which means you can take any kind of donor, and you're sort of a normal size. I think it's atypical. But if you're on an urgent list, a high priority list, which means you're dependent on inotropes in hospital, then if you're blood group A and you're 60 kilograms, you could get a heart transplant within 2-3 months. But if you're blood group O and you're 110 kilograms, that can be up to a year.
All right, so just for one minute. Say we have a patient we refer to you. What will the doing of that patient be in terms of coming up to how long they spend with you initially?
In my mind, there are 2 categories of patients. There's the group that you see in clinic that are stable, and that you see the PA pressure going up, or maybe you've had AF and been cardioverse and things. They're on optimal therapy. And they're one group of patients. I think they get referred as an outpatient. I see them in clinic on a Monday, and what happens is they'll get a cardiopulmonary exercise test. So, on that list, the cardiopulmonary exercise test is probably not accessible in your hospitals, but we have that there. They have an echocardiogram the same day, and they have BNP and everything in one day. They would see me, and then we'd have a chat about transplantation. We know their blood group, their height and weight and everything, and talk about whether they'd be interested in going on the transplant list. And if they are, then I'd do the right heart catheter, and then within a week would have an answer about whether they're on the list or not. The other group of patients are those that come in extremis with acute heart failure in your centre, or end up on inotropes, or end up on IT, or post-MI, or post-acute coronary syndrome. And they're obvious to recognise. You know, everybody recognises them and will refer. And those are the patients that are in extremis with renal failure and so on. And those kind of patients we have to rescue, usually with VA ECMO or with Impella devices. And their outcomes are generally poor. And it's almost, you know, in hindsight, you say, well, actually, 6 months ago, there was a window of opportunity then. And so there's two categories in my mind. I think those that are inpatients, you just pick up the phone. Those that are outpatients, you can have a conversation. Say, well, you know, Owais, do you think this is too early? Do you think this is too late? And we can have a chat over the phone, and if need be, they can come across. If you have CPEX tests, you have the ability to do a right heart cath, I'd be more than happy for you to do it in your own centres and then discuss the numbers. I'm not sure if that answers your question.
No, it's brilliant. Thank you very much. Final ones, enthusiastically.
Sorry, no, only that this group that clearly quite poorly, that you're considering transplantation, obviously they've got high mortality risk, complex. So how do you split them psychologically, and what proportion of them actually get to see a palliative care team?
Yep, that is a fantastic question, and I think palliative care is incredibly important. So we have strong input from our palliative care services. We've got a multidisciplinary team. We've got psychologists, we've got physiologists, we've got perfusionists, we've got VAD specialists, we've got diabetologists. We really have a massive team to support these patients. And so when they come in, they don't just get transplant LVAD talk, they get palliative care booklets and support as well. So it is really holistic, and we recognise the fact that these patients have been told something incredibly daunting, who've probably never come across this before, and it's hard to guide them through this difficult jungle and get them out the other end.
You're there. More questions? Thank you very much.